without much more further ado, I'd love to welcome our presenters. Thank you so much for being here. We have Dr. Mortazavi, who is a dual board certified pediatric sports medicine physician, and he developed the first dedicated pediatric sports medicine program in Tucson called the Sports Medicine Rehabilitation and Concussion Center, also known as SPARCC. And Dr. Mo specializes in complex concussion care for all ages and works to help patients living with brain injuries to lead healthy and fulfilling lives. So Dr. Mo, welcome back. And we're also glad to have with us, I believe for the first time, Emily Rich, who is an occupational therapist at the Tucson Medical Center, where she serves adolescents and adults with chronic conditions. Emily specializes in conditions such as dysautonomia, like POTS and joint hypermobility. And as a result of her experience with dysautonomia, Emily is now treating individuals experiencing symptoms of long COVID and rehabilitation with the aim of increasing participation as well as quality of life. And congrats to her. She is currently pursuing a PhD at Texas Women's University, where she conducts research specific to POTS and rehabilitation. So once again, welcome to you both, and the floor is yours.
Thank you. I'm Dr. Mortazavi, and thank you for that intro. I'm going to be talking a little bit today about long COVID and really the focusing on functional neurologic sequelae, namely the cognitive and exertional deficits that we see after long COVID, which really tied into what I do as a brain injury specialist, because a lot of those functional neurologic sequelae actually look very similar to those with mild traumatic brain injury and prolonged symptoms. So I'll kind of start things off and then pass the baton on to Emily, who will pick up on a lot of the focused areas that I'm going to be touching on. So quickly, a little bit about our services over at SPARCC. So, long COVID was really not part of, the obviously a few years ago, but somewhere along the way, when we started to see the research for long COVID and recognize that there was a lot of functional neurologic sequelae that looked very similar to mild traumatic brain injury, and that we had a lot of the services through our comprehensive concussion care services that could help these folks. We started to manage some of these folks at the center, along with our other sports medicine and rehab aspects. This is our team. This is our comprehensive concussion team. We also have a pediatric sports medicine team and an ultrasound-guided interventional team as well. A little bit about me. So I did my pediatric residency over at UC Davis. That's also where I went to med school, and then went on to do my sports medicine board certification, which is through the Family Medicine Board over at University of Colorado, Denver. And so my board certification and my subspecialty is across all ages, even though I have a pediatric sort of focus. And for the focus of today's talk, really, most of what we're going to be talking about, or I'm going to cover anyways, is going to be more adult-based data. So no financial disclosures. So I'll go ahead and get right to it. Talking about long COVID. So what is it? We talk about the etiology, the incidence, the course, the timeline, and really, it's been evolving, but we'll cover these things today in terms of where we're at. And initially, long COVID was sort of defined as those that have late sequelae. The expectation was, okay, it's a viral illness, and obviously it could be very dangerous in its acute phase, especially the initial strand. But the idea was after about a month that if there's still problems, that this is now a more chronic form of COVID, which we refer to as long COVID. Initially, really that 4-week mark, there was some questions between 4 weeks and 12 weeks, or 1 and 3 months as to where sort of the line should be drawn. Number of different names or nomenclature was used: long hauler, post-acute COVID syndrome, et cetera, et cetera. Most recently, the CDC has really defined post-COVID condition as persistent sequelae greater than 3 months. And that's really sort of the definition we generally are following at this point. Variety of symptoms can be part of long COVID, affecting over 10 different organ systems. And there's still a lot to be learned, particularly on the treatment management side of things. There's a lot of incidence data, which we'll cover. But with respect to what type of treatments for long COVID specifically can be helpful, these are types of research cohorts that take time and controls. And so we're still sort of waiting for the research to catch up in terms of treatment. Defining the problem. So, original studies really were, saying about maybe 5 to 15% of all folks that end up with COVID may develop this long COVID. And that was originally from the COVID symptom study out of the UK. Some of the more recent studies, like one that's really pretty fresh out, Chen et al. Is looking at, some of these numbers being quite a bit higher. And as high as 30 to 50%, depending on the country you're looking at and the type of illness that the individual had. So, like I mentioned, 2021 CDC really defining this as symptoms greater than 3 months from the onset of COVID positive, but also symptoms that have lasted at least 2 months without an alternative diagnosis. So there are some folks that maybe they had COVID 3 months ago and they are doing fine. And then somewhere along the way, they start to feel some of these symptoms, but maybe it's just for a week or 2 weeks. So that at that point, there's a lot of other possibilities. But if it's been longer than 3 months and you've had persistent symptoms for more than 2 months, and alternative diagnosis have been ruled out, this is definitely something that needs to be looked into. Again, variety of symptoms, multiple different organ systems, but really, fatigue, both exertional and cognitive fatigue tend to be big ones in this group, with neurologic, cardiac, pulmonary, and psychiatric sort of being the big players with folks that have long COVID. Here's an early sort of chart from the CDC. Back, really when the original strain was out, sort of showing that, after 4 weeks, they were looking at now late sequelae. Pathophysiology wasn't really well understood. Still, there's, a lot we don't know about the pathophys, although sort of for the long or post-acute COVID, an autoimmune mechanism is really probably the most likely one right now that's being postulated. But you can see, again, if you look at under late sequelae, that cardiovascular, pulmonary, neurologic, and psych are the big ones. And if we look here, you can see all the different organ systems that obviously can be affected with long COVID, and chronicity in all these different areas are possible. But if you actually break down where the symptoms are most common, what you can see on the left there is that, again, this concept of fatigue, both cognitive and exertional, which can go with the dyspnia, body aches, etc., are at the top of the list. So, and this is where, again, we got more and more involved, because obviously our work is with concussion and mild traumatic brain injury is very much focused around the neural aspect of things, right? Cognitive fatigue, exertional tolerance. These are all very common themes in mild traumatic brain injury. So when we started to see similar ones with long COVID, then that's where we started to get involved in some of the workup and management of these patients. So some of the studies here, if we look at the literature, some of the early studies looking at this concept of fatigue that these patients had. And this was Townsend's study early on was really independent of severity, because there was a lot of talk about how, if you're in the ICU and you've been hospitalized, then, those are the folks that we need to worry about long COVID. And certainly we do, but it turns out that independent of hospitalization, independent of being in the ICU, this is still something that occurs at a pretty high rate, relatively speaking. So here's one where they found greater than 50% of folks, again, independent of the severity of their COVID, that still were endorsing some form of quote unquote fatigue. And again, that captures cognitive and exertional at 10 weeks. And these non-specific sort of neurologic symptoms that fall under the fatigue, they could be headache, visual disturbance, balance issues, memory, cognitive fog, hearing loss, smell and taste, mood and anxiety. These are all sort of non-specific symptoms that have been endorsed, as well as in some cases more specific symptoms like cardiopulmonary symptoms of dyspnea, cough, etc. We tend to see those more in the hospitalized and ICU patients, especially if there's specific disease to go along with it, cardiopulmonary disease to go along with it. And so it's critical to rule that out, that there isn't a pneumonia, heart failure, et cetera, myocarditis. But what we see with long COVID is by far the majority of the cases, that's not it. It boils down to the functional neurologic symptoms that these folks have, or deficits that these folks have, and the lungs and the heart are generally working pretty well. Here's several early studies, very large and looking at cognitive impairment. This was a multi-center international study looking at, again, a variety of COVID presentations, anything from mild all the way, out to hospitalization in ICU. And what they found is that there was high rates of mild cognitive impairment overall, not just in ICU patients. 50 to 90% of folks with COVID and persistent sequelae having cognitive impairment. But the highest degrees of cognitive impairment were seen in the hospitalized and the ICU patients. So, and this is based on computerized cognitive testing that was done in these patients. So, and the point here being that cognitive assessment, as well, formal cognitive assessment, as well as management with things that Emily Rich would do, occupational therapists, speech therapists that can do cognitive therapy, may be needed in many of these cases. And again, in our center, because we manage mild traumatic brain injury and do computerized cognitive testing and neurophysiologic cognitive testing, we had the platform to be able to sort of assess these patients. So it made sense for us to get involved. What about exercise intolerance? So this is another sort of big area with long COVID. 30 to 50% of patients with persistent prolonged symptoms have some history of endorsing this. Again, most of these patients, and when I say most, greater than 95%, are without specific cardiopulmonary disease, meaning that their pulmonary function tests, their PFTs are preserved, their cardiac functions preserved. It is still critical to have pulmonology, cardiology rule these things out, evaluate these patients, make sure that they don't have anything that's specific to those organs that need to be treated that way. But like I said, most of the time that's not the case. But these patients still have limited aerobic capacity and limited VO2 max compared to healthy controls. And that's suggestive that there's a stamina issue, that somewhere along the way that their stamina has been reduced. And so you think about deconditioning, for example, in this group. But there's also abnormal ventilatory efficiency. There's systemic oxygen extractions are off, the peripheral vascular resistance. So this was a study done by Alba looking at these areas. And so the suggestion there is that it's more than just deconditioning, that these folks are actually having trouble exercising initially. As a result, they don't exercise, and then months later the deconditioning factor adds on top. So it's probably a compounding effect like that. And then autonomic regulation is a key player here too, and multiple studies have looked at this as sort of a key player in etiology and mechanism of exercise intolerance. And when we talk about dysautonomia, what we're talking about is the brain. It's a neurologic problem. It's the brain's capacity to be able to regulate autonomic functions of heart rate and blood pressure changes that have to happen when we exercise and even change positions. And we take all that for granted when we're healthy, but whether it's traumatic brain injury, it's something that we see where there's problems and people have to rehabilitate that to get back to normal with exercise. And certainly that's been the case with long COVID. Exercise tolerance assessment. So, in the office, there's sort of the poor man's assessment. It starts with a good history and exam, like most things, and then also asking about postural symptoms. So if they're having issues much more significant than usual when they get up from a laying or seated position, that might be suggestive that there is some poor autonomic control, and that needs to be assessed further. The sit-to-stand test is kind of a good example of a poor man's exertional test. Obviously, you need to make sure your patient can tolerate this test. It's done for 1 minute. You're monitoring for symptoms, pulse ox, heart rate. Orthostatic instability can also be assessed by orthostatic testing, where you have the patient lay for 5 minutes and then stand, and you're checking blood pressures while laying, and then also at 1, 3, and 10 minutes while standing, and asking about any symptoms that they perceive. So you that way can assess not only whether they get symptomatic with dizziness or lightheadedness, but also does their heart rate elevate too much when they get into the standing position, which would be known as POTS, or postural orthostatic tachycardia syndrome, or does their blood pressure drop too much, which would be orthostatic hypotension, and those would be objective measures for potential autonomic dysfunction. Indications for formal testing, and really formal testing boils down to being able to do formal exertional testing, monitored exertional testing, and then also orthostatic testing, and potentially more sophisticated autonomic testing. Really, once cardiopulmonary disease has been ruled out and there are still symptoms of exercise intolerance not otherwise explained by the workup, then there needs to be a further assessment here. And a lot of these patients will say they're no longer tolerating activities of daily living even. But for some, it'll be, I used to run 5K every day, no problem. Now, I do 1K and I'm really fatigued and I don't know what's going on there. For others, they literally can't walk up the stairs. So there's a sort of a variety of how subtle or not subtle the exercise intolerance is. And I think ultimately it's critical to be able to ask the specific questions to understand what your patient's baseline norm is. I used to just walk around the block versus, again, I'm an elite athlete that used to do a lot more. And once you understand that, then it's easier to figure out how far off their baseline they are and how much exercise intolerance they have per their history. And then there's signs of exercise intolerance, which can be, again, assessed by more formal tests, starting with simple tests like the sit-to-stand test. There's the 6-minute walk test, which has age-matched normative data that you can look at, orthostatic testing. And in our clinic, we do formal exertional testing on a treadmill, which is monitored, and it's something we've done for concussion and mild traumatic brain injury for some time. Mood, behavior, sleep are all important aspects to really be asking about. The psychiatric aspect it's common. 50 to 90% of patients with prolonged symptoms related to long COVID, and it's very similar to mild traumatic brain injury. It's depressing, it's anxiety provoking to be 3, 4, 5 months into something and not be better and not know why. And so a lot of these folks will have anxiety and mood symptoms. Sleep disturbance can come with that, of course. And of course, that can play into some of the cognitive fog and fatigue, because sleep is critical to cognitive function. Mood is critical to cognitive function. So these pieces start to sort of interact and compound on each other. So we can't ignore the psychiatric component. We can't ignore the sleep component. We need to identify, we need to ask the questions, understanding they're very common, and then formally treat them. Here's a cohort study by Davis et al. In 2021, looking at 7 months and basically a huge cohort of long COVID patients, close to 4,000. And they defined in this cohort, because it was prior to the CDC's revised guidelines, really 1 month as long COVID. And what they found in this cohort is, there was a variety of 25 to 50 different symptoms endorsed in 9 different organ systems, but only 8% of this cohort was hospitalized. So you're talking about 92% non-hospitalized, quote unquote, relatively mild COVID. And still, these folks had symptoms, at 35 weeks or at 7 months out. And you can see 91% at least still had one symptom by 7 months. So that's pretty significant. And again, fatigue, exercise intolerance, cognitive dysfunction were the top symptoms being endorsed at 6 months, with 88% reporting some form of cognitive dysfunction, memory deficits, about half of them having to adjust work as a result and do half-time or reduce work, and a quarter of them not being able to work at all and having to take some disability. 30% of them reported POTS or dysautonomia, and this was self-reported based on patients checking their own heart rate. And 85%, I found this very interesting, reported basically waxing and waning symptoms. They're frequent relapses having to do with the fatigue, cognitive, exertional, which again is very familiar for us to treat concussion with prolonged symptoms, because that waxing and waning, of course, where you say, one day I almost felt normal and I did too much, and then the next day I really felt awful. So there can be that as well, obviously, in majority of these patients. The Wuhan study was another cohort study. The difference is they went longer, so they went out to a year, and they also had a control, and they also had objective testing along with the surveys at 6 and 12 months. So we get a little bit more information from this longitudinal cohort study. But starting with the fact that 49%, about half of them, still had at least one symptom at 12 months. So that was improved from 6 months, where it was around 68%, but still, that's a pretty significant number. Half the patients still having some symptoms at a year. Fatigue, muscle weakness were most commonly reported here. 30% had some persistent dyspnia, and that was around 26, about the same at 6 months. So it was not, in that particular case, it was not getting better. Now, remember, this cohort was an untreated cohort, right? So this cohort is just being watched over time. But I think this goes to show that without treatment focused to their problems, then, you can't necessarily just expect recovery with time. You can see the 6-minute walk test was done at 6 and 12 months in this group, and there was no difference. Again, an untreated cohort, and so they're not seeing any kind of objective or subjective results in their exercise tolerance. They did see persistent diffusion impairment on pulmonary testing in 25 to 50% at a year, 26% with persistent mood and anxiety issues compared to 23% at 6 months. So that was really pretty level as well. And ultimately, significantly worsened quality of life measures, dyspnea, mood and anxiety scores when compared to age-matched controls. So, sorry, I'm getting a little up. There we go. Okay. So this was a very, I kind of alluded to this study recently. This is a large global meta-analysis just released in 2022 this year. Very recently, a few months ago. So many people haven't seen this study yet, but basically what's alarming about this study, and Dr. Elliott shared this with me, he's from Infectious ID, is that really when you're looking at the global prevalence of long COVID, which I told you guys previously was sort of thought to be maybe around 10, 15%, at 4 months out, they were seeing closer to 49% of all comers of COVID that are endorsing some issues beyond 3 months. So, and of course, you got to sort of, it's a global international study, so you got to look at the area, and it was much higher in Asia at 51% than North America, which was closer to 30%, but still 30% significantly more than sort of the 10 to 15% we were looking at. They also recognized that, hospitalized patients, 54% versus, again, 30% in the non-hospitalized. Fatigue was still the most common symptom, followed by memory, dyspnea, sleep dysfunction. And risk factors, those that were more likely to develop this were folks that had asthma, were female, older age, or had overall sort of signs and symptoms of metabolic syndrome, whether it's dyslipidemia or other related signs and symptoms of metabolic syndrome. this was, an important study out of Lancet to looking at long COVID. I've gotten this question a lot. Can vaccinated status reduce the risk of long COVID? It can, just like it can reduce overall mortality. It does also reduce morbidity related to COVID, and reducing the risk of long COVID by about half is part of that. So, but that, again, we have plenty of folks that have been vaccinated that still, develop long COVID. This is a study from our center where we looked at patients with persistent post-concussive symptoms. So they're already having neurologic deficits, functional neurologic deficits. And we wanted to see how the vaccine may have affected these folks. So, a lot of our patients got vaccinated. So, because there was no contraindication for mild traumatic brain injury and COVID vaccine. So we tracked them over a survey to see what the response was. And what we found is, what we would expect, about half of them had sort of the normal, vaccine response you would have for a day. But about 5-6% actually reported more of a sort of a negative response to the vaccine, where they had symptoms for several days up to a week, and they felt it was an aggravation or exacerbation of their functional neurologic symptoms related to their concussion. But the nice thing is, it was a pretty low number, only about 6%, and they all resolved, by about a week. And that's to be juxtaposed to those who developed the actual illness of COVID on top of their persistent post-concussive, and 100% of those patients endorsed that they had significantly worsened symptoms for a significant amount of time. So in primary care, there's, I've given this talk a number of times for a primary care audience in terms of how to approach patients because that's the first place patients are going to show up when at 1 month or 2 months or 4 months they're still feeling like they're not better. And I think the big things with really being able to assess long COVID is to get a complete history and exam, do an appropriate workup, and really ask the subtle questions. A lot of what we're dealing with long COVID is going to boil down to the subtle questions. This isn't, obviously we have to rule out stroke, cardiac disease, pneumonia, PE, all these things. But ultimately, once that's done, then it boils down to, okay, so, how do you feel this cognitive fog is affecting your day-to-day? How is it affecting your job? You used to do 8 hours, now at 4 hours, you're hitting a wall. What's happening at that point, right? And it's very similar, important questions when it comes to exercise. And ultimately, supportive care is sort of where primary care has been. Counseling, maybe medications, home rehab, etc., reassurance. But, I think we're, even a year ago when I gave this talk, we're at a point where we need to look at some of the other options specific to the problems they're having. If they have significant cognitive impairment, well, there are ways to treat that. We have cognitive rehab out there. People like Emily do those kinds of things and can help these patients. If they have significant exercise intolerance, there is exertional rehab that can be implemented. There's physical therapy that can be implemented. If they're having autonomic dysfunction, there are ways to rehabilitate that. So we need to look at some more targeted approaches, in my opinion, very similar to that we do with post-concussive functional neurologic deficits. Here's some nice guidelines, the nice rapid guidelines. Also, I think this is a worthwhile paper to look at, originally published in the UK in 2020, but they do a good job of really focusing in on long COVID and going through sort of the primary care assessment, including a holistic and thorough history and exam to really assess for functional impairments, including cognitive, exertional, and mood and anxiety, right? Which those are the most common ones. And then sort of goes through the laboratory workup and potentially X-ray workup that may be necessary to rule out other specific disease, the appropriate referrals that may be necessary, and then ultimately multidisciplinary rehabilitation to help these folks get better. This was a small cohort that, at this point we've got more data that we need to sort of go through. But after the first few months of taking some of these patients, we developed a small cohort of about 10 adults with long COVID. On average, they were sort of presenting to us with moderate level scores, somewhere between 4 and 12 months. So these are folks that have had, the long COVID symptoms for a significant amount of time. And we looked at their cognitive scores, their mood scores, their sleep scores. And these were the top symptom clusters, with cognitive being number one. Work intolerance was there in all these patients. They were all part-time, and 3 out of the 10, about 30%, were actually on leave on disability. We did computerized cognitive testing in these patients and found impairments in 7 out of 8. So most were able to objectively look at their mild cognitive impairment. We also looked at evoked potential, which is a neurophysiologic way to assess this, and saw suppressed P300 ERPs, which is a neurophysiologic response to a cognitive task in 6 out of the 8 patients. And exercise intolerance, we saw in 9 out of the 10 patients, basically only a couple of the patients were tolerating greater than levels of mild exertion over 120 beats per minute. And all patients were assigned an exertional rehab dose. Dysautonomia was associated with most of these patients. 25 of 28 visits where we did exertional testing, we did see positive vagal autonomic testing. And then, interestingly, vestibular ocular testing, which is something we do very commonly for concussion, was also positive. And this is looking at oculomotor, visual, and balance issues in this group using near-point convergence, King-Divitt testing, and oculomotor tracking. So I'll show you some of the abstracts that we published with this data. So, but ultimately, what this kind of summarizes is that long COVID does have these different domains. And even though cognitive and exertional may be most common, we need to look at sleep, mood, visual, vestibular as well, because similar to post-concussive, we see a variety of these different profiles or domains that are affected. Here's a study that we did looking at exercise tolerance. I sort of alluded to this again earlier, but basically 90% of patients had some level of exercise tolerance doing formal exertional testing, treadmill-based testing with them. And this was the breakdown of the underlying etiologies for why we were seeing the exercise intolerance. And you can see autonomic dysfunction in this group was the most common cause. So, this was looking at the vestibular ocular motor abnormalities. We do several different tests, including balance tests and vision tests. The KD and the NPC are both visual tests. And what you can see is, again, 80% were positive for some aspect of the vestibular ocular motor screen, which is a validated screen out of UPMC looking at balance and vision. And also, when we did the King-Divitt testing and the near-point convergence testing, you can see the red represents long COVID average versus the normative data. So clearly, very similar to what we'd see with concussion, we were seeing that the long COVID group had abnormal scores with respect to vision and balance. This is what the vestibular ocular motor screen looks like. It's basically a combination of visual as well as head and eye movement type of tests that can be objectively done relatively quickly in the clinic. And like I said, originally out of UPMC in 2014. This was, just to give you guys some context, this was this older study that we did looking at NPC and KD, in post-concussive patients. And you can see it's a similar trend where their near-point convergence and their King-Divitt scores are delayed compared to non-concussed patients. So we saw something very similar with long COVID. So this is just some examples of the different tests that we have in our concussion center to assess balance, vision. So from the top left, so that's the impact test, which is the results of a computerized cognitive test, looking at different components of cognition like memory, processing, etc. top middle is a King Divot test. It's how rapidly your eyes can read those numbers while you get timed. To the top right is an oculomotor tracking test, which can pick up oculomotor abnormalities. Bottom right is a neurophysiologic test looking at the voltage using EEG technology, looking at the voltages of the brain and how they respond to cognitive tasks. And over to the bottom left is balance testing using a force plate. And you can see the red represent where the patient is compared to the gray, which is normative. So age-matched normative. I just wanted to give this example. We do see, and we are seeing teenagers who are presenting with this as well, although less of them. So this was an example of a girl I saw. Originally, was a straight A student, ran track, and but ultimately had a relatively mild course of COVID, and then subsequently developed severe chronic fatigue that affected her academics, couldn't tolerate school, actually had to take some time off, as well as wasn't even able to jog. So this is an example of these non-specific fatigue symptoms and how they can come into play. So what do we do to help? So generally, when we see these patients that present, obviously we start with a questionnaire, a detailed questionnaire, and ask them about their symptoms. And then, we hone in on the areas that are commonly a problem. So for cognitive fog, cognitive fatigue, we can do cognitive testing that can not only assess cognitive proficiency, but ultimately also assess cognitive fatigue, which is where folks can be pretty proficient for a while, but they sort of teeter off or hit a wall eventually. We want to be able to sort of address both of those for planning for school and work, and ultimately consider whether neurocognitive rehab is necessary for some of these patients through speech therapy or occupational therapy, and sometimes even visual or oculomotor. Formal neuropsychiatric testing is also something that's available. This is a 6 to 8 hour one-on-one assessment with a neuropsychiatrist to really dive into the cognitive and the psychiatric issues. And so we don't jump to that, but that is something that is sort of on the back burner for some of these patients that end up needing it. Exercise intolerance, we basically want to assess this first, ask the questions, do formal testing, monitor exertional testing, and then from there try to determine the neurogenic causes, assuming we've ruled out cardiopulmonary, what are the neurogenic underlying causes of exercise intolerance. And like I said, autonomic dysfunction is very common reason, but it could also be vestibular, ocular, it could be deconditioning, and then start to target treatment with exertional rehab and other types of rehab like occupational therapy, targeted at autonomic dysfunction if that's what's needed. The bottom line is to get this gradual monitored exertional rehab going at the level that they can handle and allow them to build back up to their norm. So certainly support groups are important, cognitive behavioral therapy, understanding the psychiatric aspect of things, treating sleep. Sometimes medications need to be used in this arena to help patients be able to get better sleep and control uncontrollable anxiety, for example, or depression that can ultimately get in the way of everything if it's not controlled. So this is another critical part. Jeffrey Siegelman here, reflections of a COVID-19 long COVID. He's an MD who had this, he wrote this piece in JAMA in 2020, who had long COVID. And this was his article. And I recommend all you guys take a look at this or read this if you can get your hands on it. He was reflecting on long COVID at 3 months out. And really just, I think this was a great piece on for us to sort of understand what people are going through when they go through this and develop some empathy for it. Some of the points he made, again, as a doctor going through this, was that, first of all, mild illness can have dramatic effects. And lack of objective data doesn't preclude illness. Because your tests and your x-rays all look okay because you don't have specific disease. It doesn't mean that there isn't non-specific cognitive fatigue that still needs to be dealt with. He mentioned how it's difficult to ask for help because even as a doctor with all the research within the world, he felt that ultimately his symptoms weren't being validated, that when his tests were coming back normal and people expected him to be normal, what do you mean you're still tired? What do you mean you can't exercise? What do you mean you can't handle a full day's work? You should be fine. And ultimately, along with that these patients, they need validation, they need understanding and empathy. We've seen this again and again with mild traumatic brain injury with persistent symptoms. It's a very similar story, where we talk about how the outside world they don't see a cast on your head. They don't see what you're suffering with respect to cognitive and some of these functional neurologic deficits. But it doesn't mean they're not there. It doesn't mean that we still need to help you get better. And ultimately, he finished with saying he's lucky because he was someone, again, that was a doctor. He understood, he had perspective, and he ultimately had a lot of resources, which many patients may not. So again, a good piece I'd recommend you guys to look at. So the take-home points, ultimately understanding that long COVID is based on chronicity, that it's persistent symptoms, and really at this point we're looking at 3 months. But even between 1 and 3 months, if you're having issues, I think it's worth getting checked out because at that point it's probably still a problem. It can be a variety of symptoms, but ultimately the non-specific fatigue, both mental and physical, are the most common. Important to still rule out specific disease, that there wasn't a stroke, a heart attack, myocarditis, etc. But ultimately, it needs to go beyond that. Always really considering the mood and sleep issues in this population, and validation and consideration for treatment options for these folks. So, and again, services that we have, and Emily's going to talk about a lot of the rehab services specifically through TMC, but ultimately wanting to assess cognitive, exertional, and then provide cognitive neuro rehab, cognitive behavioral therapy, counseling, et cetera. There are many options for these patients. And even though, we're studying the effect of treatment on long COVID specifically, right? We've already known the effect of these treatments on exercise intolerance, on autonomic dysfunction, on cognitive impairment, right? Once you get to those subcategories, we have a lot of research showing that there's neurorehabilitative services that help those things get better. So there's no reason to delay once you know those problems are there, and you start to focus on targeting treatments to those specific areas of deficit. So I will leave it at that. I think I'm just right on time here. I think we have a couple of minutes in case there's a couple of questions. I'm going to try to hang to the end, but I may not be able to be there. So I want to, if there's any pressing questions, I want to address them, and then pass the baton to Emily and let her run with it.
Well, thank you so much, Dr. Mo. I will echo what is said in the chat. That was incredibly fascinating because it's still such a relatively new disease. We're constant, even from your last presentation, there's so much new information. And I think there's something really that hits home, like I've heard constantly when doing resource facilitation from folks who have had long COVID symptoms as well. And it's easy to be empathetic, but like I've had COVID fairly recently. And when you're dealing with that fatigue yourself, it's kind of puts things into a new perspective. So I absolutely loved that slide you shared with the doctor's personal perspective, because I think it is very important for everyone and medical professionals and everyone to work together to realize everyone's symptoms are very different. And we hear that with traumatic brain injury a lot as well. It's like you've seen one case, you've seen kind of one case. So trusting that the patient knows their body and their symptoms. So that was excellent. We did have a couple questions in answer to those who asked about the slides. I can't give an answer right now about the slides. We can talk to Dr. Mo and Emily later to not put them on the spot. But as Kristen mentioned in the chat, we will have this presentation available on YouTube in about a week. And so hopefully if anyone had issues seeing the slides with clarity, then that should be cleared up when it's made presentable on YouTube. A big question we seem to have, Dr. Mo, that we had from a couple people is if there is an overlap or any kind of things you've noticed in your clinic about adverse reactions to the COVID-19 vaccine for someone who has traumatic brain injury already, because one, Deanne, I believe in the chat, gave an anecdote about her son who had a severe response after his second shot, and they're not sure if it was caused by inflammation, but he dealt with 6 weeks of recovery, which seems like it would be more rare. So she wants to know if that's something, and someone else asked the same question, if there's a reverse reaction.
Yeah, I think that's a great question. And, Emily's presentation may touch on that. I tried to touch on it with actually presenting an abstract we put together, because this question was coming up a lot in our concussion patients. Is it okay if we get the vaccine? Because what if the vaccine aggravates my post-concussive symptoms? I already have functional neurologic deficits. And we didn't know the answer, of course, but there weren't any contraindications, so we weren't stopping people. And we also understood that COVID itself had a lot of problems. So, the benefits outweighed the risk is what, the research showed. So we had, about 100 different patients in our survey study that had gotten the vaccine while they had ongoing persistent post-concussive symptoms. And like I showed, majority of them, 95% of them, it was not an issue, wasn't any different than the normal vaccine reaction. There was about 5 or 6% of them that did have what they felt was an aggravation of their post-concussive symptoms, and it lasted for not just a day or two, but closer to a week. So, there was a small subset where the vaccine seemed to be maybe a bit of a problem maker. But when you compare it to folks that we asked, what happens when you get COVID, 100% of those patients reported that they had significantly worsened symptoms of their post-concussive for, at least, several weeks. So, again, that juxtaposition is suggestive that although the vaccine may not be for everybody, that in general, even those with concussion or persistent post-concussive symptoms would probably prefer to be protected with the vaccine against COVID and long COVID than not. So,
thank you. We had a question from Krista that looks like a good one. Any favorite recommendations for clients with long COVID related to things they can do at home to help with their recovery process?
Yeah, I think I'll, mostly leave that one for Emily. That's kind of her area. Being a therapist, she's giving people a lot of home exercises, and certainly we try to do that when people can't get into people like Emily, and try to teach them a few things that they can do for home cognitive rehab or autonomic rehab. But that's a great question. There are a lot of options, and an occupational therapist like Emily Rich would be great to dive into that. So I won't steal her thunder. I'll let her get into that.
Okay, and then some other questions that are great have to ask about, like, is there additional help in Pima? Where can I get help in Phoenix? So what we'll say is that at the Brain Injury Alliance, we do have resources and referrals to different specialists who do work kind of like Emily, who works down in Pima County, who would do that in the Phoenix area as well. So definitely feel free to reach out to us. Kristen has put our contact information in the chat, and we'd be happy to make those recommendations, because definitely the more you know, the more you know. And it sounds like Emily's presentation is going to look at the recovery aspect of that a little bit. So I'll look and see if there's any other questions. Oh, someone has a question about the SPARCC clinic, Dr. Mo. Can anyone call and make an appointment for testing and treatment at SPARCC? I have had post-concussive syndrome for 3 years.
Yeah, so I just actually popped over to the slide that has our website on there. Our website's pretty comprehensive. And I'm, happy to share this with you guys over at the Brain Injury Alliance as well. So whether it's really looking more into our services or some of the research abstracts or our different providers or how to make an appointment, it's all there. So the website would be where I would direct you, and the answer to your question is, yeah, we certainly could see you if you've had prolonged symptoms for over 3 years.
Okay, and I think I have one more question because I know we do need to move along, but last but not least was, what about treating this like other chronic viral illnesses such as EBV with immune modulation therapies?
Yeah, I think, that's a great question. And those kind of treatments really need good research behind them specific to what this virus is. And certainly there are some labs that are looking at those kinds of things, but we just don't, obviously we haven't had the time, and we just don't have enough research there on those kinds of treatments. So it's possible, if someone's willing to be part of an experimental arm, that something like that may be available to them, but it's not considered general treatment based on the research right now. Whereas when you look at, the neurorehabilitative treatment, again, that's, first of all, we're not talking about invasive treatments with side effects and those kinds of things like medications or injections. But also we're talking about established treatments for the subcomponents where the problems are for long COVID, right? Cognitive, exertional, mood, right? So we know that sleep, those things have certain treatments that are established, and that's kind of really where the focus is right now. And there may be in time some good research on other treatments, but right now that's just not there.
All right. Thank you so much, Dr. Mo. Just out of respect for time, and we want to make sure Emily has plenty of time to present.
Okay. Well, thank you so much for inviting me to speak, and Dr. Mo for sharing this time with me. Hopefully I will live up to those questions and the things that were alluded at about what my talk will be on. But I work at Tucson Medical Center in Tucson as an occupational therapist. And hopefully we're going to talk about lots of different treatment options, so that even if you can't find someone near you that does exactly what I do, you can find someone who's going to be able to help you. So these are a variety of therapies that I often recommend and believe can be really helpful. If you find someone who either knows something about this or is willing to learn. And I think that second piece is most important, that that person is willing to learn. So what does self-management mean? We're going to talk about self-management a lot here, which is that idea of what can I do at home, right? So we don't yet have a cure for long COVID. So what can we do? Well, we can look at you as a whole human being and work to minimize your symptoms in order to maximize your function and quality of life. And so the reason why I appreciate self-management so much is it really is empowering, that patients can manage their own health. They can feel confident in their abilities, and also recognize that our bodies are really wise, and we have so much resilience and so much ability to sort of heal ourselves. And sometimes we forget this, or we lose this when we get so caught up in the medical system and people telling us what to do with our bodies. But what I do not mean by self-management is that you have to figure this out on your own. We need people. And so I like to think of those people around me, those on my care team, as consultants or coaches, helping to give me a toolbox of options and then allowing me to make choices for which tools I want to use when. For example, an allied health provider, which includes an occupational therapist such as myself, as well as a physical therapist, a speech language pathologist, we're all in the field of rehabilitation. And then there's health coaches who can help with creating goals and working toward achieving them. Family members or friends, of course, play a huge role, especially if you can't find healthcare providers with knowledge. And then often peers with similar challenges, or community organizations focused on disabilities or coping with health challenges can really help out. And this has been especially true with the long haul community, as they started the support groups and really have led their own way in figuring so much of this out. So Dr. Mo talked a decent amount about dysautonomia. This is really my wheelhouse, so I just wanted to bring some additional information on this. And so A definition of dysautonomia is really just dysfunction of your autonomic nervous system. And it can present in a lot of different ways. These are lots of different specific diagnoses that fall under this umbrella term of dysautonomia. We know that more than half of long haulers are meeting criteria for some form of dysautonomia. And this is also relevant to many people with brain injury, even without COVID infection, as in one cohort of pediatric patients with concussion, 11% of those developed POTS. And then a cohort at Mayo here in Arizona found 22 consecutive post-concussion patients. They all had abnormal autonomic testing. So that doesn't mean they qualified for a diagnosis, but it's a relevance in terms of this autonomic dysfunction. So what is your autonomic nervous system? Well, it's this automatic body function system like breathing, digestion, heart rate, temperature regulation, pupillary control, salivation, sweat, all these things. And so I listed a couple of diagnoses here. Inappropriate sinus tachycardia might be the most common formally diagnosed condition in long COVID, with estimates of 20% of the long COVID patients might have this. And IST is basically just this heart rate at rest that's over 100 beats per minute. And we really diagnose it with that 24-hour reading of this mean at least 90 beats per minute or higher. And important to know that's an absence of other causes. So medications and other medical conditions, if those are factoring in, then you wouldn't qualify for that diagnosis. Probably the most well-known is POTS, which requires this 30 beats per minute change in heart rate when you go from laying down to standing up. And we know that long COVID and these conditions like POTS are more common in women. And so overall, we know autonomic dysfunction is common in long COVID, with 67% is what a recent study showed, which would mean 5.9 to 17.8 million people in the US are experiencing autonomic dysfunction. This was presented in the Journal of American Medical Association, JAMA, a really well-respected journal, with increases in heart rate in long COVID. And then there's been many other publications. This doesn't mean, again, that all of these folks will have a diagnosis, but it does mean they're having symptoms. So it's worth developing this foundational understanding of this important system in our body. And this is one of the first things I do when I meet someone in the clinic. And so I wanted to just show you a little about what this means. So broadly, you can see this division. This is very grossly described, but of a sympathetic nervous system, which is like our fight or flight response, and our parasympathetic nervous system. So although this is overly simplified, if someone is experiencing more of that fight or flight response, if they feel more jumpy, if their heart is racing, these other symptoms often occur as well. So we might see light sensitivity, dry eyes, difficulty with seeing things close to you because you're worried about looking at your periphery, you're scanning for a threat. You might have dry mouth and more shallow or rapid breathing. Your digestion is very commonly impaired because this is the system that affects your digestion. And then circulation differences, so maybe cold or clammy hands and feet. Another important thing for us to define is chronic fatigue, and this medical definition or medical diagnosis of ME/CFS, or myalgic encephalomyelitis. And so in itself, fatigue is the most common symptom of long COVID in pretty much every study. And it's this persisting sensation of full body exhaustion, which is different from sleepiness. And it might feel like your arms or legs are being weighed down by bricks. It might be similar to feeling like you have the flu, and it doesn't get better no matter how much you sleep. ME/CFS is a condition that we used to just call chronic fatigue syndrome, but now we understand there are changes in the brain and the physiology in patients that experience what's called post-exertional malaise. They also have unrefreshing sleep, cognitive impairment, or orthostatic intolerance, or that difficulty with positional changes. And it's traditionally been associated with infection at the onset, like parvo or Epstein-Barr virus, which is known as mono. So we are seeing this in a percentage of long haulers. Just to get a sense of what fatigue feels like, fatigue robs us of our ability to think clearly and our motivation. Your body feels like it's powering off like a dying battery. So just to clarify, post-exertional malaise is not happening in all long haulers by any means, but it is a common characteristic of ME/CFS. And so there's a category of people who I think this is really important for them to understand. It's not just fatigue, and it's not just in people with long COVID. But some key elements of PEM are that it follows minimal physical, cognitive, or emotional exertion. And it's characterized by this delayed onset. So it's not right after or during the activity, but it might be a whole day or two goes by and then it hits you. And then also this prolonged duration. So it might last days or even weeks or more. And also the symptoms are unique in that they're much more flu-like. So you might have a fever, swollen lymph nodes, those kinds of things. If this sounds like your kind of fatigue, our approach to exercise would be different. And so some examples of PEM by the CDC are, taking a shower and then you're bedbound or unable to do things for days, or attending your child's school event and then you're housebound for a couple of days and unable to do basic daily living tasks. So what we really want to focus on is treatment. So I'll do my best to get through these slides, and you'll have access so that you can take screenshots or pictures with your phone later if you miss, and if I go too quickly through these, which I probably will, just to give you a heads up, but the content is on the slides. So what I'm really focused on and concerned about as an OT is this idea of managing and function in daily life. And so we know that I might not be curing long COVID, but we look at quality of life, the emotional and the psychological pieces of coping with this chronic, what's turning into a chronic condition for many folks. And so overall, I want you to hear that the biggest key is adaptation. Adaptation is really essential, and it's not always easy by any means. So managing fatigue, the number one symptom in long COVID, we look at, there's two different types of fatigue. There's primary fatigue, which is due to the condition itself. And then there's secondary fatigue, which is indirectly due to having the condition, maybe caused, for example, by getting poor sleep or nutrition, changes in your routine, activity levels, and then additional stressors, which can also affect your mood. And then fatigue, importantly, can be an invisible symptom. And many people, family members or coworkers, misunderstand this and think someone's not trying enough, or they just need better sleep. And if you've experienced it, it's much more than that. We also know there's at least 3 different categories that impact our overall energy levels. And Dr. Mo alluded to this, of this physical energy. So what you traditionally think of as energy. And then we also have our cognitive or thinking demands that place demands on our energy levels. If I have to work really hard to complete a task, or if I'm having a social conversation, or cope with sensory stimulation, bright lights, loud sounds, that will impact my overall energy levels. And then finally, your emotional shifts. So highs and lows. Something really positive, really exciting or happy, but also really sad, or you're angry. Both of those extremes can be very energy depleting, or they can be restoring. And so learning that balance for the emotional piece. The ultimate goal is preventing fatigue in the first place. So rather than trying to claw our way out of this deep hole of fatigue, we'd rather try and be proactive. So learning what your triggers are for fatigue can be huge. And I'm going to give some examples of this in a minute. Also, we want to use concepts of pacing every day. So everybody paces themselves, but when you have fatigue, you have to really think about that even more. So, taking breaks during an activity, not ever pushing through, thinking about like a stoplight. And if you're on yellow, really thinking about, should I keep going? Definitely not to when you hit red. You want to prevent hitting red and that crashing effect. And it's better to take a break and then go back to it in, 5, 10 minutes, 60 minutes, whatever it is. We also want to think about how efficiently we can use our energy. So working smarter, not harder. And this can be positional changes. This can be sitting down, using different assistive devices. There's lots of tools. Here's several triggers. I think that's really something that people don't always recognize. So these are just some that are common. And I'd recommend you kind of think about these and whether or not they're affecting you. So if you are having constant fatigue, how can we make changes? And I alluded to the idea of energy efficiency, right? And so these are some ideas about how to be more efficient and how to use your fuel rather than like a gas guzzling truck. How can I use my fuel more efficiently? Spoon theory is sometimes helpful. If you've never heard of that, it's worth looking up. The idea that, you have this amount of energy in a day and you need to spread it out, pacing yourself throughout a day and throughout a week. Here's a few specific examples that you can come back to, but the idea of getting the most bang for your buck. So sitting down, like I mentioned, is one of the best things that you can do. You can save like 25% of the energy that you would use standing up. Trying to avoid scheduling all of your medical appointments on the same day. Using adaptive equipment, delegating and tapping into support systems, all those kinds of things. Even the non-COVID populations that we saw had a decrease in their sleep quality during the pandemic, where less than half of people had refreshing sleep. So we know sleep issues are a challenge, but on top of that, we know sleep issues are a challenge in people with autonomic dysfunction and in long COVID. And so these are a few ideas. Sleep is an entire lecture in itself, but there's an app that I really like here called Cbti Coach. Also, you can look up programs for cognitive behavioral therapy for insomnia. There's a variety of those online that you can pay for. The app is free and it has resources. And then, there's these very typical basic things that we need to incorporate for sleep, especially when we're having difficulty with sleep. It's that much more important to not use screens at night and to, have a really dark environment, no sounds. You might use white noise or a fan to block out any other sounds, that kind of a thing. This slide does not need to mean exercise in the traditional sense. And so I like to talk about movement for lots of different reasons. Exercise can be hard for people to think about, but it's really important for most people in their recovery. And it's all about finding the right dosage, finding the right activities. And so the first thing we like to do is identify what your baseline is, right? So how much fatigue are you having? Are you able to do your daily activities? If you're not even able to do those, then we want to consider, what is the minimal amount of exercise, because we don't want exercise to become the only thing you can do in your whole day. So we like to encourage people to start in a seated or laying down position, especially people with dysautonomia. This often is more tolerated on the nervous system and by the body, with eliminating the effect of gravity. And movement actually helps to boost your red blood cell volume, which can help your symptoms in the long term, even though it usually makes people feel worse while they're doing it. So it's really walking this line of, I'm going to feel worse. How much worse is okay? What's the right amount to push myself? And we want to do a combination of strengthening and also cardiovascular exercise. So what types of activities might be helpful? Well, I give some exercise examples here, mostly that are seated or laying down. But the best thing is going to be the one that you stick with, right? So finding something that you actually enjoy, whether that's swimming or getting involved in Pilates, finding a group class potentially, or a virtual class that you could do. Sometimes that's more motivating. Having an accountability buddy or partner that maybe also has long COVID, or just, wants to be more active, and those can help you with follow through quite a bit. And I always encourage people not to move to upright too quickly. So, really monitoring your symptoms and not being afraid of this in any way, but just to say, if you're starting to feel like it's too much, you might want to go back to some of these laying down or reclined positions. There's a lot of barriers to exercise for people, which makes it sometimes challenging to cover, but the studies that we have on POTS specifically are very varied in terms of who's able to tolerate it or not. So I think that, taking several steps back from what you might think you should start at is usually a good idea. Starting low and slow, and then going up as you can tolerate it. Finding a knowledgeable professional can be a huge, huge piece. And there are programs virtually now if you can't find someone near you. And then motivation is a huge factor, as I sort of alluded to. People don't feel good when they're exercising typically. And so, just monitoring that level of fatigue, seeing if it's falling more into that really prolonged or delayed onset, or if you recover the next day and you're able to kind of move forward. Dysautonomia International is a nonprofit organization, and their website has lots of helpful resources to get started, including links to YouTube videos for pool exercises, which can be really helpful because of the anti-gravity effects, and then also the compression in the pool. When exerting, I prefer to use this Borg rate of perceived exertion scale. So we know that tachycardia or heart racing is really common in long COVID. And rather than focusing so much on the heart rate and trying to stay in a certain heart rate range, I think often it's helpful to think about what's my exertion. So how much breathlessness am I having? How hard am I pushing myself? And so I usually encourage people not to go above this sort of 4 to 6 when they're starting. So you can hold a short conversation, and I'd say, just start talking out loud. Can I talk right now? Can I speak multiple sentences? And if you're labored in trying to get a sentence out, you're more at that 7 to 8 level, which is great, as you progress to get to that level, but always starting out at that light level and then ending your exercise again at that light level too, but getting to that harder level in the middle. Symptom logs can be very helpful for you and your healthcare providers, whether you log in a journal or using the notes in your phone or on an app. You don't need to be too obsessive about it, but just being curious and trying to have this experimental mindset of like, you are your own case study, and what did I feel like today? Did I do anything differently? And sometimes this can be really empowering. Hydration, this is especially important for those with dysautonomias. So if this applies to you, you can reference this. I always encourage people to get the information from their medical provider in terms of how much fluid and sodium that they should be taking. But what we know is people with POTS, for example, really need more water and more salt. And what happens is when you have water and salt, you increase your overall blood volume, which is the amount of blood that's circulating through your body, and often means you won't have as much heart racing. If you've got more blood, you don't have to pump it as hard to get it up toward your brain and to your heart. So if you have myocarditis or high blood pressure, or somebody told you you should not increase your salt, do not follow these recommendations. And I think, monitoring your urine output is really helpful. So if you're drinking a lot and it's just going right through your body and your urine is, very clear, and you're urinating all the time, you might benefit from some sodium so that you can actually absorb that fluid. Otherwise, if you're not going to the bathroom hardly at all, or it's very yellow, you probably need some more fluid. I think all of us in the desert always need more fluid, but especially these folks. And so this is just sort of a visual depiction of what it looks like before you have the water and salt versus that blood flow being able to get to the brain. And here's a homemade recipe, but there are lots of products out there that I had on the last slide too, that you can purchase. And then in terms of, low blood volume being a type of POTS, that's not the only type of POTS that benefits from this. So even people who are more in that adrenaline rush or that fight or flight state more often, we actually found that they had less, this author found that they had less norepinephrine, which is basically that fight or flight response. And they had a decrease in heart rate. So it can be helpful for many different reasons. Compression garments are sometimes recommended if especially you're having blood pooling, if you have a form of dysautonomia, or if you're noticing your feet or your legs are red or purple colored, especially when you get out of the shower. That might mean that you're having some pooling in your lower body. And so using waist-high compression leggings, ideally at this 20 to 30 milligrams of mercury or higher. Those can be really helpful, as well as an abdominal binder, like this one that just wraps and wraps around your body. Those basically help to passively push the blood up towards your heart. I'm going to pause here because I know this is so much information, and we know that majority of people are having some level of cognitive impairment or brain fog. And so if you need to get off of this webinar and you can watch it at another time because it will be recorded, then sometimes that's a good idea to help with your fatigue and your cognitive energy. But newer research is showing that it's the degree of brain fog is the equivalent of 10 IQ points dropping. Now that doesn't mean IQ is actually dropping, but that is what people are feeling in terms of their function. So this is significant. An autonomic perspective is this idea of regulating those basic biologic needs before you're able to use those higher level cognitive skills. And so if you're in that survival or fight or flight mode, you're probably not going to be able to use those higher level functioning skills of your brain. And so that's one way to think of it. There's lots of theories about what is actually happening in this, and hopefully we're going to have a lot more research soon, but lots of different theories proposed. We know it exists and it's real, so what do we do about it? Well, at this point in time, lots of compensatory strategies. So remember when I said that adapting would be key? It doesn't mean that it's going to get better, but often what triggers it, thinking about what makes your brain less efficient, and on the other hand, what makes your brain more efficient. And so that can make your function and your ability to use your skills much better. So some things to think about are keeping a routine that's easy for the brain. The body and the brain love routine. Staying organized can help reduce clutter and just that idea of being able to focus on one thing at a time. We know that we can't actually multitask. There's no such thing. What we're doing is we're switching back and forth really quickly, which is really exhausting. It's really fatiguing. So on that note, letting the brain rest. Don't jump from one thing to another, letting the body process things. Considering how anxiety and depression might also be playing into cognitive function, and making sure you ask for help if that's something that you need, which most people, I think, with long COVID can benefit from some psychological supports. And then sensory regulation can be really impactful. For example, using a weighted item like this weighted lap pad. When given the right dosage and the right weight, it can help with regulating that nervous system and organizing your brain. This is a tool I like to use with patients called the Healthy Mind Platter. I'm not going to go into it here, but you can write it down as a resource to look up. And it's basically the ingredients for a good day, cognitively and psychologically. I like to highlight this idea of time in, which is this time spent reflecting internally, downtime, which is, not focusing on something, just letting your mind wander. That helps with creativity and spontaneity and new connections in the brain. We know the brain is neuroplastic. It's constantly flexible and remodeling. And so we want to fire those areas that we want to come back online. Rest is also essential. And this is just an idea of what a weekly schedule might look like, incorporating, several of these concepts. We're nearly at the end. I just briefly wanted to touch on the idea of loss of smell for those who haven't regained it, which is about 12% of people after COVID. And then some studies suggest improvement can occur within even a year's time in 60 to 80% of people. So, if it's been 6 months, don't be disheartened. There's still a lot of possibility. We really shouldn't dismiss this loss of taste or smell. It can be a safety concern. People might not have as much nutrition as they're not interested in eating foods. Safety concerns. There was a little boy in Texas who called 911. Both of his parents didn't smell smoke, but he woke up and went to them. So this is not to be taken lightly. And so there's not a lot of research on this, but there's more research than ever before on this idea of smell training. So this is really for your reference. And I'd really recommend working with a professional if you like to do something like this. And then I love talking about autonomic function. Hopefully you can find someone that can help you with this, but the idea of biofeedback, or learning about what's going on in your body through heart rate variability training, thermoregulatory, or your hand, how warm or cold your hands are, muscle tension, and if you're holding tension and you don't realize it. And then there's also these wearables like the Leaf, which is pictured here, the Welltory app, several others there. And this is just a video of what biofeedback looks like for heart rate variability training. More than 40% of long COVID patients have dyspnia, and this idea of shortness of breath, especially when they're exerting. And we think that this is similar to POTS. This is resulting in reduced carbon dioxide, which has a lot of implications. So increasing your carbon dioxide can help. This is one study in POTS patients. Basically, they used abdominal breathing, and then they added in some breath holding, and they found significant improvement in symptoms. So if you are interested in this, I think definitely trying to work on abdominal breathing, just putting one hand like this woman has on her chest, but then the other on your stomach, and trying to get that belly to be where the breath goes in and out from, rather than shallow, short breaths. So I often encourage people, rather than take a deep breath, think about taking a slow breath. You might be symptomatic at first, but the more you practice it, the better you'll get. Make sure if you do this, you're in a safe place, because some people really do get symptomatic. And then managing breathlessness in general for long COVID, we know that in the short term, pursed lip breathing can be helpful, which is basically like birthday candle breathing. So you're making that pursed lip, and it's a long, slow exhalation. Also changing positions. So there's a few positions on the left side here, this forward leaning, resting your arms in your head, or your head in your arms, leaning or resting like he is on that bar can help with breathlessness. Standing with some support in your back. And then also what we call like high side lying, like this bottom picture. You could put pillows under your head so you're not tensing up. But those are some positions that can help with breathlessness. And then long term, like I mentioned, practicing breathing. We always consider like the history of trauma. If you've been on a ventilator, we know that breathing can be triggering. And so working with someone if that's possible for you, but breathing in and out through the nose and using that diaphragmatic breathing. Self-compassion is another one of my favorite approaches for self-regulation from a psychological perspective. It's gentle and validating, and there's lots of research on health outcomes. But it's understandable to have emotional challenges when you have this kind of significant change to your functioning. And so this is really worth looking up. There's some great resources here. A few more resources that can be helpful. Some support groups specific to long COVID. And then a summary. So autonomic dysfunction is common. Treatment for long COVID includes lots of compensatory or ways to modify or adapt, and also rehabilitative, like movement, strengthening, gaining skills back to maximize your function and quality of life. And so these are the main ones that I have talked about here today. And I think self-management interventions are often really helpful. So I'm happy to take questions for the last couple of minutes. If we have a little bit of time, you can find me on social media to ask more questions if you'd like, but yeah.
Thank you so much, Emily. It's really nice to kind of have a roadmap and a nice guide to see kind of through that brain fog that you were discussing. And there are so many symptoms. And as we've said, upteen times, it affects everyone so differently. So thank you so much for these resources and this information and your wonderful presentation. Your bookend to Dr. Mo's. We have in the chat some thank yous for your awesome presentation as well. We do have a question from Kara. I don't know if this is something that would be something you would know about, but someone was curious about your findings as they might relate to lymphedema.
So lymphedema is a different mechanism than this blood pooling idea. That's your lymphatic system. I think I've read some things about, definitely the lymphatic system and the ability to drain. That's your garbage disposal system. It's a different mechanism though. So the idea of using compression for lymphedema is to help with that lymphatic fluid, where this is more about blood pooling. So hopefully that answers that. I don't really know of a link between either of those, but I don't know. There could be something out there that I'm not sure of.
Yeah, I think what we're continuing to see is that it's better to kind of realize that sometimes research is still needed. There's so many
absolutely
intersectionality with different kinds of conditions, and so it seems like we're still kind of trying to figure those things out.